This has actually become one of my favorite lectures. The first time I was asked to give this lecture was actually here. And I thought they were a little bit crazy because at the time, rush was really only used in adult patients, and I was kind of upset that I had to put a lecture together for it. But now I'm glad because I use it all the time. And I think there's definitely there hasn't been any research done with this. We're, of course, starting research on this, but I think this is really going to help all of us take care of children better in the future. So basically we'll start off by talking about the different types of shock, and then how ultrasound can actually help us distinguish which types of shock patients are coming in with. And then we'll finish with cases and what my proposal for a pediatric rush would be. We all know, all of us deal with pediatric patients. Shock is especially difficult with them. I mean, hypotension, it's a late finding. Kids are always tachycardic. Are we blowing it off because they're crying? They have a fever. It's really hard to tell. So I think especially for pediatric patients, this can be very useful. Now, of course, in contrast with adult patients, we don't have as many cardiac etiologies, but it can certainly help us with the other forms of shock that they present in. Shock in general has become a lot more important in the literature with sepsis guidelines and things like that. But I think also pediatric populations have been a little bit neglected. So hopefully this can actually help us in the future. And obviously we want to optimize patient outcomes. So as a review of the different types of shock, obviously the intensivists, this is kind of their thing. It's a little bit less of our thing in the emergency department. So I myself had to kind of review the different types of shock. So this we see every day, hypovolemic shock. Kids are vomiting, they're dehydrated. This is almost every hour in the emergency department, I feel like. So also acute blood loss and trauma situations. So that one's easy. A little bit less easy, distributive shock, but you can see this with sepsis. Your vessels are dilated and you're pouring out fluid into the periphery. You can also see this with drugs and anaphylaxis and adrenal crisis. Obstructive shock, now this starts to go into a little bit less common for pediatric patients, but certainly they can come in with these things. Obstructive shock includes pulmonary embolus, pneumothorax, and pericardial effusion, and you'd actually be surprised that this is much more common than you think, and to keep it on your differential when a patient comes in shock. And of course, cardiogenic pump failure. So all of those kids with congenital heart disease, they are at risk for cardiogenic shock. And especially if you work in a pediatric center, you'll see a lot more of these kids. So it's just kind of an easy overview of the different types of shock and what you'll see. And now, once you have this understanding pretty firmly in your memory, then we'll kind of see for each and every type of shock how ultrasound can help us. So the RUSH protocol, this was developed for adults. This was not developed for kids. This is why I was a little bit late to knowing about the RUSH protocol. I think Brett gave the lecture initially, and I learned a lot from that lecture. So the RUSH protocol stands for the Rapid Ultrasound for Shock and Hypotension. And you can remember a couple of different ways the components of the RUSH protocol. Some people will call it the pump, the tank, and the pipes, and I'll show you what that is. And then another way is called HIMAP. But whichever mnemonic you use to remember the RUSH protocol, there are different components that you have to do, and I'll go over each and every one of them. But you can do all of this entire exam with the phased array probe. So you don't have to switch probes. Sometimes you may want to for part of the lung exam. but the phased array probe should be fine for all of them. So now the pump, the tank, and the pipes. There are different components of the pump, the tank, and the pipes. Pump is easy. That's exactly what it sounds like. It's the heart, the cardiac ultrasound, and you're looking for contractility. Is there good squeeze, yes or no? Now the tank has three components. You have the inferior vena cava, and you assess for collapsibility or respiratory variation. The fast, are you losing fluid into your abdomen? And thoracic, are you losing fluid into your chest, such as the case in a pneumothorax, effusion, or pulmonary edema? Now the pipes, the aorta and DVT, and I'm sure all of you who take care of children are looking at this and saying, we don't really care about that in kids. So yes, this is true. It's not a never that it happens in children. I have an N of 1 of a 7-year-old who had a AAA. So I can no longer say this is never applicable to pediatric patients, but I'm not necessarily going to do this exam on everyone in order to identify one patient in my entire career. So just keep that in mind. I had mentioned HIMAP. This is a mnemonic to remember the components of the Rush protocol, and that stands for heart, IVC, Morrison's, aorta, AAA, and P for pneumothorax, or you can remember it as pulmonary for lung. I'll reinforce this and I'll do this over and over again that we don't need to do AAA for kids. Goal is to complete this entire exam in less than 2 minutes. How many of you think you can actually do that? Everyone's like, no way, in the back. So I can promise you that you can do this in less than 2 minutes. Also keep in mind that you're not doing initially a complete cardiac exam, a complete IVC, a complete fast, a complete comprehensive lung. That would be impossible. We're only doing a few key views, and if you find something abnormal, you can do additional views. So it is doable, and I encourage you all to practice this. So I'll just warn you right now, I like disgusting pictures of animal organs from when I travel. So here's the heart, and the questions that we're going to ask when we evaluate the heart are about the contractility. Is there good squeeze, yes or no? Is there an effusion present, or is there tamponade? So you can use a couple of views. The subxiphoid view is very easy. This is also something that's done in your FAST exam. In addition, this is a view that is ideal in the case that you are actually doing compressions. So you have the probe here, you can get ready, you can get the heart in view as someone is doing compressions on the anterior chest. So you can imagine parasternal long axis view. While it is very helpful, and I'll show you that, if you're doing compressions, you would actually have to pause compressions in order to put the probe on the chest, and it would cause a lot more delay in actual compressions. So try subxiphoid, and then if you need to, parasternal long as an alternate. So again, we're looking for effusions. We can evaluate for asystole and global function overall. This is the subxiphoid view. When I first started doing cardiac ultrasound, it was really difficult for me to remember what structures are what. So the way that I tend to remember it and teach it is that if you remember one structure, the right ventricle is the most anterior structure, you can figure out the rest. So just remember right ventricle is the most anterior structure. Subxiphoid view is the only one that has liver on top. Right ventricle, I mentioned, is the most anterior structure. Then you'll have left ventricle, right atrium, left atrium. Now it's important, this is a 4-chamber view. It's not the traditional apical 4 that we're used to seeing, but this is a 4-chamber view that you can get a lot of information from this view. When you get this view, make sure that you change the depth and make sure that you see it enough to see the posterior pericardium. Very important. And this is what it looks like in real time. And as you're doing these images, now that really almost every machine saves video clips now, there shouldn't be a reason to save still images. So always save video clips of the heart. So someone who's looking at your images later can actually look at a lot of information like contractility in real time. So here you go, right ventricle, left atrium, right atrium. So here's an example of pathology. You can see here, liver on top, right ventricle. There is a circumferential pericardial effusion, that anechoic fluid all the way around the heart. This is one of the components that we use to diagnose sonographically tamponade. Other things that you can find, here I want you to look at the right ventricle. You have diastolic collapse, or what's referred to as scalloping of the right ventricle. And then when you're looking at the IVC, and we'll go into this a little bit more in depth, you see really no variation of the IVC with respiration. So you have dilated IVC without any respiration, without respiratory variation. And here, ultimately, this is severe tamponade. This is a swinging heart. If you don't have a needle in your hand, or if you don't have cardiology ready very closely, you should. This is a very ominous sign that the patient is about to crash. So I mentioned parasternal long axis as an alternative view. Now again, if you're doing compressions, this is not ideal. You want to minimize pauses in compressions. But for a lot of other things, if you have a stable patient, you're looking at the parasternal long axis, and this will give you a systematic way of evaluating for contractility. So luckily, Brett and I both do the same orientation for the probe and the indicator. So indicator for parasternal long axis is 4 o'clock. And this is what you're going to see on the screen. Now, do you remember what the most anterior structure was? Right ventricle. Right, so right ventricle is on top. And then this view, the most of what you see is actually the left ventricle. So you see a lot of information. You get a lot of detail of the left ventricle. Then you have the aortic outflow tract stacked and parallel on the left atrium. Now, one structure you never see here is the right atrium. So this is not a 4-chamber view. Now, in real time, this is what you're going to look at. You want to make sure that you have your probe oriented so that you have the aorta parallel and stacked in the left atrium. Here you have the mitral valve, and you want to look at it for contractility. So contractility, this is moving a little bit past your basic assessment. Is there squeeze, yes or no, or asystole? Is there an effusion, yes or no? So this is a very, very basic way of evaluating for contractility. And we're really only looking, is there good squeeze, yes or no, or is it depressed? Now, when I first started doing this, I was like, yeah, it's squeezing okay. But there are specifics that you can actually look at in the parasternal long axis view to evaluate this. So here we have right ventricle, most anterior, and you have the left ventricle. Now, first, you're going to look at the septum and the squeeze of the posterior wall of the left ventricle. You're looking at the left ventricle, the cavity of the left ventricle, and how it changes with contraction. Then this posterior wall, you'll notice that with contraction, that wall gets thicker. So you're looking for that as a sign of adequate contractility. Now here, remember, this is the mitral valve. You're looking at the anterior leaflet of the mitral valve and how it moves, if it moves in the direction towards the septum. So those are the things. Now we're going to go on to examples, just to kind of train your eye of how to evaluate for contractility. Now remember, you're looking for these three things: the posterior wall thickening, the change in size of the left ventricle, and then also the movement of the anterior leaflet of the mitral valve. So we'll start with this one. That's actually a really good question. Yeah, on these, I'm using the abdominal setting. So there are some, actually the institution where I am now, they like doing the cardiac setting. Just know, and the way you can tell, so this one's at in the abdominal setting, it's at 4 o'clock. Right, in the cardiac, it's flipped. Yeah, so it makes, all of these are really confusing, and like I've been doing it this way for my whole life, and then, you know, the past 2 years I've been in an institution that does it in the cardiac setting. So I have to, in my head, flip it around. What I would say, this is super confusing, and no one's willing to really come up with one way of doing it that would make it way easier for you guys to learn. So what I would recommend is just sticking with one way, doing scans that way. And I would just say the exception is if you're at an institution that they do it a particular way, you kind of have to do it their way. So I have had to change my practice, but I still do this, then just in my head I flip it in order to accommodate for the indicator placement. But that's really important when you're scanning. I think, you know, whether you change the indicator or you change the setting, the reason why I like this way, 4 o'clock in the abdominal setting, is that this is the image that the cardiologists see. So the left ventricle is here. So not all scanning happens that way. But I like having the same image that the cardiologist sees. So then that way, when the cardiologist comes and looks over my shoulder, they don't think that I don't know how to scan. So that's my personal opinion, but everyone feels very strongly about their own way is the right way. Okay, so parasternal long axis, we're going to start off easy. We're just going to focus on contractility. There are two components. You have contractility, and then you also have kind of rate, right? So contractility, good squeeze or bad squeeze, those are your two options. And then if it's fast or slow, hyperkinetic, hypokinetic, and then normal in the middle. So those are the three options, and contractility is either really good or really bad. And cardiologists would probably cringe at this, and I usually apologize to cardiologists. But for me, this was really difficult to understand initially. You can always build on this later, but if you understand the initial principles, then it'll just make it a lot easier later. So age matters with rhythm, right? Whether it's hyperkinetic or hypokinetic. So let's say this is a 6-year-old. Does that look about right? Hyperkinetic or hypokinetic? It's probably about right? So what about contractility? So that's what I just told you about. You look at the posterior wall. Is it thickening? Yep. Septum, is that moving towards the posterior wall? Yep. What about the anterior leaflet of the mitral valve? Yep. So we have check, check, check. Yes, yes, yes. So normal or bad contractility? Normal. Okay, so that one's easy. That was the same exact video that I showed you before. That makes it easy. So this is less easy. So let's say this is a 14-year-old. So is that normal, too fast, or too slow? So normal, hyperkinetic, or hypokinetic? It's hyperkinetic, so it's moving fast. Now, here's the thing, that when you have a hyperkinetic heart, it's often really difficult and distracting to evaluate for contractility. So it may be fast, and you're like, oh my God, that's not normal. Yes, it's fast, but then you want to kind of step back and focus on the actual squeeze and those three components. So that posterior wall, is that thickening? Yes or no? Yeah, it's thickening. It's not the best image, admittedly, right? So that's thickening. Is that moving towards the septum? Kind of hard to see because it's so fast, but it is. And then what about the anterior leaflet of the mitral valve? Yeah. So even though this is a really good example, even though it's super fast, it's still good contractility, right? So this is only hyperkinetic, but you still have good squeeze. So don't let that confuse you. So now here's kind of a similar example. So don't let the fast nature confuse you. So I'll tell you it's fast and hyperkinetic, but let's focus on the squeeze. So this posterior wall of the left ventricle, is that thickening? Nah, not really. What about the movement of the septum? Not really. What about the anterior leaflet? It's just kind of like kicking out. Anytime I see just valve movement that's just jumping out at me, more valve movement than maybe the heart movement and wall movement, then that's a problem. So this one is just like you're seeing this kicking out of the anterior leaflet of the mitral valve. So that's not good. So the squeeze itself is not good, but sometimes if you're just looking at rhythm and whether it's hyperkinetic or not, that'll confuse you. So this is hyperkinetic, but you have poor function or poor contractility. So now what about this one? So let's say this is a 1-year-old. Is this hyperkinetic, hypokinetic, or normal? It's a little bit slow, right? You're like, oh, I just want that heart to move. Like I feel like you just want to give it a push, right? So it's not doing a whole lot. Now, what's the thing that you notice really more than anything? Valve movement, right? So you can see valve movement here, aortic valve and mitral valve. That anterior leaflet of the mitral valve is just kind of kicking out a little bit. It's not moving very far, but you see movement of it. What about that left ventricle, the posterior wall? Is that thickening? Not really. Is this changing? Not really. It's dilated and it's just not doing a whole lot. So this is a very sad heart. So that's pretty poor function. And this is a pediatric patient, and this function was not known. This kid had a prior echo a month before and had normal contractility. So this was an immediate call to the cardiologist. Now what about this one? Any age, doesn't matter what age. Yeah, pretty much, that's yuck. So that's not only poor function, but that's actually asystole. If you have a little bit of valvular movement, that doesn't really count. So you see the wall, it's not moving. You can almost like barely even see what kind of view this is because it's just such bad function. Left ventricle is over here. But I mean, really, anytime also that you see dots of blood, any kind of bubbles, that means that there's stasis of the blood, and that's really bad. So not a good prognosis for that one. So any questions before we go on to IVC? That's the most complicated part. That's a little bit new. The rest is just review. The rest of the views are a review. So now for the IVC evaluation, I won't go into complete depth because you don't really need a whole lot of depth for IVC, and I'll show you why. So essentially, we're looking to see if there's respiratory variation or collapsibility. That's the question. So now for probe placement, again, this is part of your HIMAP, your RUSH protocol. You can use a phased array. It's best to find the IVC in transverse or cross-section and then rotate with the indicator towards the head. But make sure that you maintain the probe perpendicular to the body and also at the midline. So you can use the umbilicus as your landmark. If you're off a little bit, you may be looking at the aorta, unfortunately. So make sure that you're really a stickler about maintaining that probe perpendicular and in the midline. When we look at dehydration for the IVC, this is not a study that you rely on solely. This is just extra information. This is one part of your HIMAP. And essentially, you're looking at the respiratory variation. Now, with respirations, we all know that there's change in thoracic pressure. So with expiration, the IVC will expand. And with inspiration, it contracts. But a good way to remember is expiration expands. Now, what we're going to see on transverse, we're initially starting with the indicator to the patient's right. And I love these Netter views because it's exactly what you would expect to see. So probe is perpendicular to the body, indicator to the right. And what you see here, you'll see IVC, aorta, spine, which corresponds to the ultrasound image. Here's the IVC, here's the aorta, and here's the spine with shadow. So these are the three things. I cannot emphasize enough that the indicator orientation is super important. So if you accidentally flip the probe or if you're in the cardiac setting, if you're looking at this in the wrong view or indicators in the wrong place, you're going to be looking at the aorta. And there's no respiratory variation in the aorta, so you may be looking at it incorrectly. So now, in order to get the IVC longitudinal view, you go from indicator towards the patient's right and rotate towards the patient's head. Now, keep an eye on the monitor of the ultrasound as you do this rotation, otherwise you may lose your target of the IVC. Now, you also want to remember the IVC is on the right side of the patient and the aorta is on the left. So as you rotate towards the head, you may have to angle your wrist just slightly over to the patient's right to actually get the IVC and slightly towards the head. Because what you want to do is see the IVC as it courses through the diaphragm. So on the ultrasound image, these are the structures you'll see. You'll see liver on top, the hyperechoic diaphragm, and the longitudinal IVC. So you always want to see the IVC coursing through the diaphragm because otherwise you may be actually assessing the aorta. Now there are a few different ways that you can evaluate the IVC. People have done measurements, which ideally would be for research purposes, and the Gestalt method, which they haven't really researched much, but I'll show you what that is, and whether there's respiratory variation. Now the studies, it's not the best study, and this is the reason why. When I was a fellow, they thought that the IVC was going to be this really important study for pediatrics. And one of the initial studies looked at IVC aorta ratio. Because as children grow, obviously their size of the IVC and aorta are going to change. And this was a way of correcting for that. The other option would be to try and develop a growth curve for the IVC, but I never wanted to do that study. You would have to enroll a ton of patients to develop a growth curve. I really don't want to do that. But in any case, this is a way of trying to correct for that patient's growth. So what they found was that the IVC aorta ratio was lower in dehydrated children. So they tried to validate that. So they studied and they looked at a cutoff. So they used a cutoff of 0.8 centimeters for this ratio. Sensitivity was pretty good, of 86%. But look at this specificity, 56%. You'd be better off flipping a coin. Now, if this hasn't told you that the IVC is not really all that reliable, This is my favorite study because this actually proves it. Lorraine had actually looked at patients in the ICU who had a CVP monitor, and they looked at IVC measurements. They looked at collapsibility index, which is one of the measurements, and they looked at the IVC aorta ratio, and they did not correlate with the CVP. So that to me means that not that we shouldn't be using IVC, but maybe that we shouldn't actually be relying on measurements. Because when you actually, if you just go and perform measurements, if you're off by just a tiny little 0.1 millimeter or whatever, you're going to change this number dramatically. So for me, measurements are pretty useless, but the Gestalt method is really much better. And what that means is with dehydration, you'll have a lot of respiratory variation. You'll have greater than 50% variation, and the walls of the IVC and the longitudinal view almost touch each other. So that's just looking at it grossly, quickly. This is also better for your HiMAP because it's just going to be a quick assessment rather than monkeying around with measurements. In contrast, on this side, this is actually a patient who's breathing, but you can barely see any kind of respiratory variation. That IVC is huge, and you see barely any movement in a plethoric patient. So moving on to Morrison's FAST, this is just a super quick review. Is there fluid? Are you losing fluid? And is there free fluid in the thorax? So this is just a quick reminder of all the views of the FAST exam. So you don't have to do all of these views. A lot of people will suggest that you just use the high yield view, and that would be Morrison's in adult patients. Remember, the indicator is towards the patient's head, angled back in order to maintain in the plane of the kidney. And what you're looking for here, and you see in the ultrasound image, you can see liver on top, kidney, and that space in between is Morrison's, and you're looking for any kind of fluid there. Side by side, this is normal, and this is an example of a ton of fluid that I don't think anyone would miss. Usually in real life, they're a little bit more subtle than that. And make sure at this view, you can also look above the diaphragm. So you're already answering in one view above the diaphragms. You're answering the question of whether there's fluid inside the chest. So as a quick reminder, you have the liver here. This is diaphragm. Above the diaphragm in a normal chest, you have this mirror image artifact. So it looks like liver, but it's just hazier. Now, if you have an effusion, you don't have that mirror image artifact. And you also have something called the spine sign. So the spine continues when there's fluid because you don't have air obstructing it. So here you have liver, kidney, the spine continues. Here you can see the spine stops at the diaphragm. And then you have the spine sign. So I add in this because I had mentioned this briefly when we talked about the cases yesterday. I wouldn't solely do a Morrison's view in a kid. So even if a kid has a liver laceration or splenic rupture, they may not have fluid in the right or left upper quadrant. So this is important to know. We think that it's probably before puberty is the cutoff. With puberty, the anatomy of the pelvis changes, so that might be the reason why. But we found that suprapubic view is helpful in prepubertal children. So as a quick review, start with the transverse view. It's easier to find. You can maintain midline here using the umbilicus as the landmark. Indicator is towards the patient's right. And this is the study that we did, that regardless of the location of the lesion, most kids actually have fluid in the pelvis. So this is what we're looking at on ultrasound as a quick review. You have the phased array probe that you use for the rest of your HiMAP. You see your bladder as a rectangle, and you don't see any anechoic fluid deep or posterior to it. So side by side, here's the normal pelvis with the bladder, and abnormal is this anechoic fluid posterior. Make sure that you decrease that far gain in your TGC so that you can actually see this fluid. So it's worthwhile to get two views. Because the suprapubic region is a very important view for kids, it's worthwhile to get a second view. Rotate the indicator towards the patient's head, and then you'll see this anechoic fluid here. It's helpful because the wall just kind of lights up. You'll see the borders of the wall of the bladder. So I told you I wouldn't talk about aorta DVT. That's why I have it on there and I cross it out. Lastly, we have our P in HiMAP, and this was traditionally for pneumothorax, but it's also for pleural effusion and pulmonary edema. So you can get a lot of information for this study. So you can still use, I mentioned the phased array probe, but you can switch over to the linear probe. I personally like the linear probe better, especially if you're looking for a pneumothorax. You have a lot more detail of that pleural line. And in a lot of the machines these days, you can actually just push a button and it easily switches over. So you're not really wasting any time. Now, we already did the right upper quadrant. We looked above the diaphragm. Fluid is there. We're looking for fluid. Now, where you're actually looking for these things, it actually makes sense, right? So fluid will sink to the bottom and air will float to the top. So you're going to look for an effusion down here above the diaphragm when we did the Morrisons, and then you're going to look for air on top at the anterior chest. What you're looking for is rib shadow with a pleural line in between, and that's called the bat sign. In case you guys can't see the bat, that's the closest thing that I can come to actually simulate why it is a bat. In any case, a lot of these things are a little bit difficult to picture. What we're looking for is we're looking for lung sliding. So side by side, this is normal lung sliding. You can see that movement of the pleural line against each other, the visceral and the parietal pleura. You can see these tiny little comet tails coming off of it. Some people actually describe this as ants marching, and this is just that sliding. This is in contrast to a pneumothorax where you actually don't have the sliding of the visceral and parietal pleura. So you can use M mode if you're not sure, and to confirm this, you're looking for the seashore sign. And if those of you who can't actually picture this, I'll put a picture on top to explain why things are called the way they are. Here's ocean and the beach, and the ocean is on top. You have the straight lines, and then that wave is that pleural line, and then the graininess is actually the sliding. So when you have a pneumothorax, you don't have the waves and you don't have the beach. And this is called stratosphere for pneumothorax. Some people will refer to it as a barcode sign, but that's not actually how Lichtenstein initially described it. Now, for those of you who don't know what stratosphere is, which I didn't, I had to ask Lichtenstein because a lot of these names bothered me. And so he has reasons behind everything. And this is because this is a very ominous sign. It reminded him of warplanes going across the sky. So it's the smoke lines, and it's very ominous. And you'll notice if you look in my textbook, I actually do not ever refer to it as barcode sign because he doesn't like that. In any case, back to what we're looking for. So we looked for pneumothorax on the anterior chest. We already had seen this. We had already done right upper quadrant. But just as a quick review, for effusion above the diaphragm, you don't have that mirror image artifact there. So also B-lines. Other things that we can look for are B-lines. Remember B-lines, this one is just going to have one giant one. You think about B-lines as appearing as a flashlight. So that goes all the way to the bottom of the screen. When you have a lot of B-lines, so some people have a couple of B-lines and that's okay. When you have a lot of B-lines, it's a B-line pattern. It can refer to an interstitial syndrome. So it's a lot of information. How do we tie this all together? So this chart to me is very helpful because when you have certain findings on each of these components of the HiMAP, then you can divide out what type of shock you have. So back to the hypovolemic, the distributive, the obstructive, and the cardiogenic shock. Now this is pretty easy. The pump, if it's normal or hyperkinetic with good contractility, it's either one of these two. So you've already divided it in half. And if you have bad contractility, it's either obstructive or cardiogenic. Now, when we're looking at lung, we look at sliding or the B-lines or effusion, so that can divide it out as well. So that makes it much easier. And we're just gonna know that with the pipes you can get more information. If you have a high-risk patient with complex medical history, you may want to consider doing DVT or AAA. So now let's go through some cases. First case, we have a 14-year-old, and these are all cases that I had. 14-year-old female with history of liver transplant. Now, this was one of those days that I walked in and I was tired. I walked in with my coffee, and there were like 2 patients in the ER. So I was like, no problem, just stroll in. I got sign up from the night person, and they had said, oh, this is a liver transplant patient. She was already seen by the transplant surgeon, so you don't have to do anything. Great. So sit back, drink my coffee. Then I look over at her and I'm like, why does she look that bad? I think I may have to do something. She's sitting up straight, and her monitor is going crazy because her vital signs are completely out of whack. So she's super tachycardic, she's huffing and puffing. She's 14 years old, she shouldn't be breathing that fast, and her heart rate shouldn't be that fast. And I was like, wait, do you want to tell me what's going on with this patient? Like, maybe I should actually figure this out. I'm like, well, no, she was already seen by the transplant surgeon. She got a stent placed. There was an interventional procedure. She got a stent placed in her liver. She's just waiting for her bed. There's nothing to do. I'm like, well, did they do a chest x-ray? No, they didn't need it. They wanted to avoid radiation. Okay. So I'm like, well, she's looking bad. She's looking bad. And then she starts to become like a little bit wacky and not making sense, and her blood pressure goes low. So then I'm like, all right, get up out of my seat. And admittedly, I will tell you, this predated HIMAP, so I didn't do it in this order, but I'll present it in this order, just so that it makes a lot more sense. So you can look at the heart first. So remember, this is a 14-year-old. Looks pretty fast, right? So it's hyperkinetic. So try and ignore the rate, but let's look at the contractility. Wall thickening, yes or no? It's kind of hard to see, but it's probably, right? You can probably see movement of the anterior leaflet, and you can see change of the size of the left ventricle. So the squeeze is pretty good, so I don't think it's her heart. We can move on to IVC. So this is longitudinal IVC. And what do you think? Dehydrated or plethoric, or somewhere in the middle? So are the walls touching? They're almost kissing each other, right? So that's just way dry. Why is she dehydrated? She's not vomiting. She doesn't have diarrhea. I don't know why she's dehydrated. She's losing fluid somewhere. So let's look at Morrison's. So we look at Morrison's and there's nothing, but we look above the diaphragm, and what is that? Does anyone know what this thing is that's like floating around? So it's compressed lung. So there's a ton of fluid here around compressed lung. And I was like, oh my God, what is that? Why is that? So then you go on to aorta, that's fine. We're looking for pneumothorax. We'll come back to that finding, I promise. So there's sliding on the left side, but then we go over to the right side and we're looking for sliding, and it's dark. Why would it be dark? Can you see sliding there? So you can't see sliding because there's fluid in the way. So it's black. So it's not necessarily pneumothorax, but you just can't see sliding, there's fluid. So turned out she had tons of fluid in her chest. Why would she have tons of fluid in her chest? So they put in this stent and they accidentally nicked her diaphragm. Whoops. She had a huge hemothorax, and she went to the OR. They sewed up the little hole, and she was fine. Yeah. So had she waited for the transplant surgeon in her bed, then we would have had some problems. So that was a surprise. Definitely woke me up. Didn't need coffee for that one. This is a little bit more common that you'll see. I mean, we saw this all the time at big children's hospitals. 6-year-old female with ALL, fever, neutropenia, and fatigue for a day. She was tired, but her mental status was fine. She was pretty typical for a 6-year-old. Warm and mottled, delayed cap refill. True to our standard, we did labs, we accessed her line, gave cefepime, and gave fluids. I don't do rush in everyone, otherwise I would be doing scans on way too many patients. I'll give them fluids first, so I know this kid has a reason. She may be septic, she's febrile, she has neutropenia, so I'm gonna give her 60 cc's per kilo of fluids. Not within an hour, of course, but you can do 20 per kilo at a time or 40 per kilo at a time, whatever you'd like. But my threshold is usually about 60 per kilo. Now, if I'm giving 60 per kilo and the patient is still tachycardic, and definitely if they're hypotensive, then I'm taking the ultrasound machine out and I'm doing my rush protocol. So first we look at the heart. In retrospect, I probably would have done parasternal long axis more. But what you can see here is our left side and our right side. And remember, this is after 60 cc's per kilo of fluids. Now, what jumps out at you right away? So it's not the same view that we're used to for parasternal long, but which side is bigger, the left or the right? The right is much bigger. It's not supposed to be that way, right? You also see same principles that we saw in the parasternal long axis. The valve movement is much more than the wall movement. The left ventricle, the cavity doesn't change much. So we have a problem, right? This was actually one of the times that, actually in many situations, when you're trying to convince the ICU to take your patient, this was very helpful. because I said, hey, listen, I've given 60 cc's per kilo of fluids. And they're like, well, why don't you give more? I'm like, I don't think so, because this heart isn't working very well. And then you have more evidence, and you can even see on the IVC here, we're full, our tank is full. Our IVC is nice and full. There's barely any respiratory variation. So even with these two parts alone, you can tell your intensivist, you need to take the patient. I'm happy to show you the ultrasound images, but we need inotropic support. Fluids are really not going to do the trick. So in this case, M was normal and aorta wasn't done. And then if you need more evidence, you can look at the lung and you can see a bunch of B lines are forming. So you have poor contractility, your IVC is nice and full, you're not going to give more fluids, and you need inotropic support. So our last case, and actually now you're probably going to, I guarantee you're going to look at your patients a little bit differently after today, because now both of my fellows have discovered this. This was actually my prior fellow, so 2 of my prior fellows have discovered this. And I wonder how many of these patients I've missed this pathology. So this was also a case of being careful about a diagnosis that's given to you. So 8-year-old was sent from another hospital. We were a referral center. And the kid came in with acute abdominal pain, and they thought it was a perforated appendicitis with sepsis. Okay. So he had luckily just done his adult ultrasound rotation. And he saw, hey, this patient's in probably septic shock, so I'm going to do HIMAP. And this is what he did. So I purposely am going to save H for last, and you'll see why. So here's the IVC. So you see longitudinal IVC here. They could have probably decreased the depth a little bit, but you can still see, is there respiratory variation? Yeah, there's respiratory variation. Are the walls almost touching? Yeah, it's dehydration, right? So we're losing fluid somewhere, whether it's sepsis, who knows why. They did M for Morrison's. There was no fluid at Morrison's. And they didn't do A because it's a kid. So then they go on to P. And what do you see? So is that normal lung or not normal lung? Not normal lung. Why is it not normal lung? You see a ton of B lines, and these are coalescent B lines. So this is already a problem. So we're like, ooh, is this fluid overload, some kind of interstitial syndrome? And here's heart. And this is why I did it last. Because this was not a case of perforated appendicitis, but what is that? So this is subxiphoid view. Oh my goodness, this is a pericardial effusion. This patient was in tamponade. That was not what they were expecting at all. That was not on the differential. So lo and behold, cardiology was called, and they did a pericardiocentesis. So a lot of surprise things that you can find. And you can, obviously, this fellow actually saved this patient's life. So that's always cool. So I know that's a lot of information. I promise you that you can do this in less than 2 minutes. But just keep this in mind as a way of, I know I heard a laugh over there. I promise. You can really treat your patients better by figuring out pretty quickly what type of shock they're in. Just do it as a systematic approach. That's why there's HIMAP. There's a way to remember it. So heart, IVC, Morrison's, AAA, and pneumothorax, and just make sure that you use this with all other information. Now, I have to put a plug for future research. I want more people to do research in this in kids. Now I have a lot of fellows. So we're starting a study there, but I think over nationally and internationally, I think people need to use this more and study it more. This is my proposed pediatric modified rush protocol. Now, this has not, again, not been studied. This has not been documented anywhere. There's a case series that just describes the use of pediatric ultrasound in the rush. So I also would like, since I'm switching it around, let's go with physiologic priority, right? So physiologic priority, we would do airway, breathing, circulation first and not wait. So pulmonary, especially in kids, you're going to look for pneumothorax. Here's an example of lung point where you can see the sliding meat, no sliding. We're going to look for tamponade, your IVC, and either suprapubic or Morrison's. That is my proposal for the future. Hopefully you'll see more of that soon.